Hello
Hello,
everyone.
everybody.
Today we have another episode of Principles of Surgery course, and I'm happy to introduce our today's speaker, Dr. Edward Goldberg, who will be giving a lecture on ulcerative colitis. Thank you, Dr. Goldberg, for joining us.
Very welcome. So last time I talked about Crohn's. This lecture will focus on ulcerative colitis, but I will also contrast it with Crohn's. There's not that much to really say about ulcerative colitis. There's a lot more to say about Crohn's. And so by juxtaposing them, hopefully it will solidify what we talked about last time and bring in the highlights for ulcerative colitis. Okay, I have nothing to disclose relevant to this subject matter. So as everybody knows, ulcerative colitis is in the colon and the rectum only. It does not involve the small intestine unless you have an incompetent ileocecal valve, and then you get some effluent from the colon refluxes back into the ileum and can cause what's called backwash ileitis. But basically, it is only the colon and rectum. It starts distally in the rectum and it moves up in a continuous fashion. The one association that has not to do with the GI tract is when you have primary sclerosing cholangitis of the liver. This makes you at increased risk for liver cancer as well as increased risk for colon cancer in the affected colon. So the variant of UC that also has PSC makes people much sicker and more susceptible to cancer. The goal for ulcerative colitis is to cure the disease by removing all of the colon and restoring the GI function. This is different than Crohn's disease, where we aim to manage the disease by resection of the affected areas. Because Crohn's affects the GI tract from the lips to the anus, it's impossible to cure it because you can't resect it all. And so we take a much more measured approach with Crohn's disease. As I talked about, it's systemic. Anywhere in the GI tract, it skips around. There's also effects of liver, eyes, skin, and other areas. But as you can see, here are some areas. The common patterns are ileocolic is A, B is small intestine, C is colon only, and D is rectum and anus. The goal for Crohn's disease, as we mentioned last time, was to treat the complications, failure of medications, and to prevent complications of the medicines, which are things like steroids and some of the biologics. So here's some pictures of ulcerative colitis. You can see on the far left of the screen is a normal colon. In the middle is very mild disease. It's injected, but it still looks smooth. And on the far right is a moderate disease. Severe disease, you wouldn't be able to really see even the mucosa looking with any normality. So as you can see here, this is a picture of ulcerative colitis that affects the entire colon, with the cecum and the appendix being on the left of the picture, and the right is the end of the colon and rectum. And the thing here is the disease, you can tell, is not severe. This is fairly mild disease, except for in the hepatic flexure. Let me see if I can show you. You can see my arrow right here, hepatic flexure. But over here, what you see is loss of all of the haustra, or most of the haustra of the colon. And over here, you can see that it's less pronounced on the right side, but on the left side, it's really very pronounced, loss of the haustra. Sometimes when you see these patients in the office, you'll do a rigid sig, and you see a patient, and a really simple test is to do a rigid sigmoidoscopy. And when you insufflate air, you won't see any distension of the colon. It'll just be kind of rigid-like, a rigid-like structure. And when you do that, you know that it's lost its distensibility and that there's significant disease. So what are the indications for surgery? The elective indications are failure of medical management, steroid dependence, if they have dysplasia, or if they have strictures. Strictures because you're really concerned about cancer, dysplasia, the same thing. And somebody who has chronic anemia, who you can't get the inflammation under control and they're anemic, could also get surgery. The urgent reasons are toxic megacolon or perforation and hemorrhage. So the goal is to eliminate the disease and restore function. So you would just take out the entire colon and restore GI continuity by creating a new rectum. So the first operation, which is the best from a cancer standpoint and a symptom control standpoint, is proctocolectomy with an ileostomy. That removes the entire colon, rectum, and anus. There's no chance of cancer. There's no chance of complications from the pouch, pouchitis, development of perianal disease, or anything along those lines. The next option is, and most people don't opt for number one, and most people don't opt for, and most surgeons don't offer a proctocolectomy with a continent ileostomy, which is basically a ilioanal J pouch, but within the abdomen, and that's called a Koch pouch. The third and fourth choices are colectomy with iliorectal anastomosis and proctocolectomy with iliopouch anal anastomosis. Number three would be offered for somebody who had colonic dysplasia, but a rectum that was free of dysplasia, somebody who might, a young woman who's concerned about fertility, who has dysplasia in the right or transverse colon, doesn't have rectal dysplasia, is worried about fertility, and has a relatively spared rectum from disease. Because remember, as you give medicines for inflammatory bowel disease, the patients will get differing responses in different part of their colon. And the nice thing about the rectum is you tend to have fairly good response in most people, and you can also use topical agents. So in somebody who has contraindications to an ilioanal J pouch, colectomy with iliorectal is certainly within the repertoire of what to do. And that used to be the standard operation for people who couldn't get a J pouch or before J pouches were routinely done. And then the last one and the most commonly used operation is total proctocolectomy with iliopouch anal anastomosis. So here's proctocolectomy. You can see the entire colon in white is gone, and the person has an endoileostomy. A Koch pouch, you can see the picture here. It's just an internal J pouch with a nipple ball valve, and you just catheterize it and it empties the liquid. Total colectomy with an iliorectal is this cartoon. You can see the ileum is hooked to the rectum here. And here would be a J pouch. Total proctocolectomy. You fold the ileum on itself, make a anti-mesenteric incision in the small intestine, fire a linear stapler or hand sew by opening up the bowel on the anti-mesenteric border and hand sewing the back wall closed, and just coming around and hand sewing the anterior wall. Stapling is certainly much quicker. And then you, nowadays, instead of taking out the lining of the anal canal and doing a mucosectomy, we staple at the levators and we put an anvil into the proximal bowel and we do a double stapled technique. And everybody gets a loop ileostomy. Here's a cartoon picture of the J pouch in the pelvis with a loop ileostomy upstream. That's a picture. You can see this patient has had a J pouch, but you can see by looking at the face, the patient has had lots of steroids, too much steroid, and is very cushingoid. So a J pouch will allow the patient to get off the medicines. So you can do this open versus laparoscopic. There's some benefits to each one. We can talk about those. Open surgery is much faster, better view, easier to see if the J pouch will reach the pelvis. The downside, generally longer stay in the hospital, more pain, bigger incisions, more complications from the incisions. Laparoscopic, shorter incisions, fewer adhesions, faster recovery. But you have a limited view and you can't really feel what's going on. So here's what I was talking about before. You have a rectum, you have ileum here, the anus here, and you just staple across right here, anvil, and you have a stapled anastomosis. If you leave this little cuff of rectum or the lining of the anal canal, it used to be popular to do a mucosectomy. And when you do that mucosectomy, you strip off the anal mucosa and then you hand sew down into the cuff below the mucosectomy. The problem with that, it leaves islands of mucosa behind. So in a patient with dysplasia, you're actually leaving some small islands of mucosa behind the J pouch that's advanced into the anal canal. And then the patient can get cancer behind that. So you get less, if you do the mucosectomy, you don't generally get anal cuffitis or inflammation at the anal cuff, which can be pretty easily managed with rectal suppositories, but you don't get that. But you have, and you have these islands of mucosa behind it, which can't be surveyed for cancer. Another benefit of doing the double stapled is you have better control because the patients have better sensation of liquid. So the anal cuff, if you have loss of sensation, patients don't, they can get a loss of sensation and have more nighttime seepage. So in general, J pouches, patients do pretty well, 5 to 6 bowel movements a day. During the day, very few people, 1 in 20, will have some leakage. It's usually at night. The medications that we use, that you need to use for the J pouch is Imodium, Lamodal, cholestyramine, fiber, whatever the product is here in the United States, it's Metamucil. Patients will get pouchitis, 25% of them. That's inflammation of the pouch, which is treated with antibiotics first. It's treated with usually ciproinflagyl or augmentin. It's all, which is amoxicillin, clavulanic acid. It can be treated with probiotics. It can also be treated with short course of steroids or biologics. Patients who have bad colitis are more likely to get pouchitis. Patients who have a J pouch for FAP, multiple colon cancers, or dysplasia with mild disease tend not to get pouchitis. People, it's about a 5% chance that you will not be able to do a J pouch at the operation because it won't reach. That's an anatomic consideration. It won't reach. There are some maneuvers to make the J pouch reach, so you can free the mesentery all the way up to the root from the retroperitoneum along the SMV. You can make little anti-mesenteric fenestrations or cuts in the mesentery overlying the ileocolic vessel, which is the apex vessel, to make the J pouch reach. And you can also take the second arcade away from the bowel. So if you transilluminate the ileum and you look, there's an arcade right under the bowel, and you'll see the branches go up and down and they go circular like this. You can take right where the apex of the bowel is, you can take the second arcade. You can take a second arcade because there'll be collateral flow, and that'll give you a centimeter or two. And those are the general ways to get a J pouch to reach. People talk about S pouches. They talk about W pouches. I've been practicing 25 years, and including in residency, I never saw one or felt the need to do one. They always say that an S pouch reaches because you have a little spigot on the end, but so few people do the S pouch that people aren't proficient at it. So what I always tell people, and what I do, is if somebody is heavy, say somebody has a body mass index of 32 or 33, I make them lose weight to get under a BMI of 28. I mean, under a BMI of 30. I've never had a problem getting a J pouch to reach with the BMI under 30. If somebody has a much higher BMI, I would then do a 3-stage process. I would take out the colon and give them an ileostomy, leave the rectum. And then I've had patients get bariatric procedures, get sleeve gastrectomies, get Roux-en-Y gastric bypass. They'll lose weight, and then I'll go back and take out their rectum and create the J pouch. So it just depends. But we do 2-stage procedure and get patients to lose weight. So even despite that, if you go into the operating room and somebody is, 8 to 10 centimeters away from the J pouch reaching, it won't reach. and that person just needs their rectum out. If it's 10 centimeters, won't reach. If it's 3 to 4 centimeters, 5 centimeters, getting people to lose weight and doing the other maneuvers that I talked about, then the J pouch will reach the pelvic floor. The easiest way to tell when you're doing your surgery if a J pouch will reach is right at the base of the symphysis pubis, right at the base of the penis. There's a little notch in the skin there, and it's in the same position in a woman, just above the top of the vagina, above where the clitoris is. And you can feel, if you feel at the symphysis pubis there, you'll feel a little notch. If you take out the ileum out of the abdomen and you make where your J pouch is going to be, where you think the piece that's going to reach the most, if that piece of intestine, if you move it over like this, if it gets to that little notch, the far side of the symphysis pubis, then it will reach underneath. If it's on the other side of the symphysis pubis, and it doesn't even get down to the top side of the symphysis, then you're going to have problems getting it to reach. The second 5% reason why people lose their pouch, which is over time, I think it's more like 8 to 10% over the long term lose a pouch, is because people develop Crohn's, they get fecal incontinence, they develop a pouch vaginal fistula, they develop strictures, they have chronic pouchitis. So there are a multitude of reasons why people do. People also get complications. They get pouch torsion, they get afferent loop syndrome. All of these can lead to loss of the pouch. So what is the indications? I have up here familial polyposis, but it's really mainly ulcerative colitis. There's probably 10 pouches for ulcerative colitis for every case of familial polyposis. Most patients have really good outcomes. The other reason, and the important thing, two things to talk about with J pouches and with ulcerative colitis, is the risk of cancer. So the risk of cancer really starts to go up at the age, after the person has had colitis, ulcerative colitis, for 10 years. And then the risk of cancer is the societal risk, which is about a 5% lifetime risk, and then about 0.5% per year of having colitis over 10 years. So somebody who has a 40-year-old, let's say a 45-year-old, has a 5% chance of having colon cancer in a Western, in an industrialized country like the Ukraine, the United States, most of Europe, a lot of South America. So you have a 5% chance of having cancer, and then you've had colitis for 20 years. So 10 years over the first 10 years gets you another 5%. So that person with a 20-year history has about a 10% chance of cancer. They get up to 30 years, it becomes about it comes about a 15% of cancer. 40 years, 20% gets very high. I think something that's interesting is I'm seeing more and more young people with dysplasia, and that probably has to do with they have both the colitis and they have the increased risk of young people who are getting colon cancer nowadays, which I know you're seeing in the Ukraine and we see here. So there's an additive effect with UC as well as young onset colon cancer. And so how do you screen these people? You screen these people by doing a colonoscopy every 1 to 2 years. You use chromoendoscopy, which is you use saline with methylene blue, and you spray on the surface of the prepped colon. And as you come out, the interface between putting the methylene blue in there will show you any lesions or areas of concern that you can biopsy. You should do 4 quadrant biopsies every 10 centimeters coming out of the colon. So you'll have, probably 50, 60 biopsies as you're coming out when you're doing that. And you just do those biopsies for surveillance, and you biopsy anything that looks abnormal, and you biopsy randomly normal looking disease. If people have high-grade dysplasia, their risk of cancer is anywhere from 15 to 40 to 50%, depending on which literature you read. So typically, if people have high-grade dysplasia, we might do a repeat colonoscopy in 6 months, and if it persists, then they go to surgery. Low-grade dysplasia will continue to follow people, but if they have 2, 3, or 4 episodes of low-grade dysplasia in the same area and it's not, going away like it was a random finding, then we recommend surgery for those patients too. The high-grade dysplasia is flat dysplasia, meaning you don't see a lesion. If you see a polyp or you see a raised lesion, or you can see an area that you can identify, even if it looks like maybe a serrated adenoma, that can be resected. None of us here, let's assume, have ulcerative colitis. If we had a polyp resected that had high-grade dysplasia, we would be done. We would just go about our life. So we used to always do proctocolectomy in people who had dysplasia, even if it was in a polyp. Now that is not correct. If they don't have a polyp, or if it's flat dysplasia, should they get the proctocolectomy. And that has to be flat dysplasia that's high grade, that is on 2 consecutive colonoscopies 6 months apart. Okay. Let me think, what else? I did surveillance, I did that. Oh, now we should talk about 2- and 3-stage procedures. A 2-stage J pouch is when the patient comes in with dysplasia, the patient is not on steroids, maybe they've just failed Remicade, and they're not on any other immunosuppressives at all. Then I would do a proctocolectomy with a J pouch and a loop ileostomy. Unfortunately, in this day and age, the vast majority of patients they're on steroids, they're on biologic, and they might even be on methotrexate, or they've lost a bunch of weight. And patients who have lost a bunch of weight, they're on active steroids or more than one immunosuppressive, or they're in the hospital with a low albumin because they've had a protein-losing enteropathy from their colitis. In those patients, I would then do a 3-stage procedure, which is take out the colon, laparoscopic, give them an ileostomy, let them recover, get off of their medicines, and 4 to 6 months, generally the longer time frame, I make them wait 6 months. I then go back, take out the rectum, and do a J pouch. After that, I then would get rid of the ileostomy in 8 to 12 weeks. And that's what I would do for patients. I think with Crohn's disease, we talked about toxic megacolon. It's the exact same management. Somebody comes in with ulcerative colitis, they have toxic megacolon. You want to rule out C. diff and CMV colitis. You want to pulse them with steroids, give them antibiotics, aggressive fluid resuscitation. You can start, if they're not on it, biologic therapy, generally with high-dose Remicade, and you want to get at least serial KUBs. The reason to take people back to the operating room for that would be failure of management or perforation, anemia, or bleeding from the toxic megacolon. The right operation for toxic megacolon is a total abdominal colectomy with an ileorectal anastomosis. And then what I do is I don't get rid of the rectal. I don't make a mucus fistula for the rectal stump. I don't implant it in the incision. What I do is after I've stapled the rectum off, I oversew it with a Prolene underneath the staple line to give it a buttress, and then I irrigate out the rectum with a rigid sigmoidoscope. I put the rigid sig in, I evacuate everything, and then I put warm saline in, and I irrigate out all the effluent that's in the rectum, and I air test the rectal staple line, also under saline, to make sure that it's intact. And with an intact rectum, and once you irrigate everything out, I then put a Penrose across the anal canal to stent it open so that stuff will come out and the patient won't build up toxic material in the rectum. And I think that covers toxic colon, surveillance, increased risk of cancer. We showed lots of pictures of the procedure. So I think what I'll do is open it up for questions. This is the shortest of the 3 topics I've covered.
Thanks, Dr. Goldberg.
Very welcome.
And okay, and the question to the participants: do you have any questions for today's lecture?
Yeah, this is all additional Crohn's disease. No questions?
Okay, I see first hand. Markian, please.
Oh, Markian. Where's Markian?
Good evening. Thank you very much. Is there any contraindication for laparoscopic surgery for the ulcerative colitis or Crohn's, in your opinion?
I think for Crohn's disease, if somebody's had multiple operations, you could always put in a laparoscope, Markian, and see how many adhesions there were and what you could what you could accomplish. I think that, so I do robotic surgery, and I would love to come if you guys have a robot and show you how to use the robot. I would be delighted. And I think the robot offers an enormous amount over laparoscopy. First of all, it's much easier on the surgeon. You sit in the corner, it's like playing a video game. You're not standing at the body. The only difference is the ergonomic problems with the robot is you develop carpal tunnel like I have. I have not insignificant carpal tunnel. I could lose 30 pounds, so I'm working on that, and maybe the carpal tunnel will get better. But in general, people get carpal tunnel from the robot, but they get neck, leg, hip, and arm problems from laparoscopy. You guys are all young, but I'm 59 tomorrow, and surgery takes its toll on the body, especially if I've done 17,000 operations, so I'm starting to feel the effects of standing that much and working. And so I do think that the robot offers more advantages because you're sitting. For instance, I had a person, maybe in October, I did a robotic ileocolic resection for Crohn's in a young woman. She had a leak and developed a pelvic abscess. I was able to do a redo ileocolic resection using the robot because of the triangulation of the instruments and the fact that you have arms that and you articulate at the wrist. It's not straight in. And so you articulate, you have the ability to suture, you have stapling device. So I found that to be much easier. Doing robotic rectal cancer as an example. I've injured a branch of the internal iliac vein and I've sewed it closed. I've gotten into presacral bleeding, and using the right angle, you can just literally put the right angle into the hole and just put cautery on the outside, and it'll transduce and it'll cauterize, the presacral bleeding. You can, if you do a coloanal anastomosis, you can sew reinforcement from the inside. My point is laparoscopy is fine and robot is fine. I think as we do more and more of these and we do redo operations, we'll get better at it. I've done redo diverticulitis robotically, and people do it laparoscopic. So I don't think there's any per se contraindication. I think in 20 years, I would say now, if I had somebody come in who had toxic megacolon with a perforation, I would not do that robotically. I would make a big incision and I would have their colon out in under an hour. Right? You can't even position and do the robot without 45 minutes. Do you see what I mean? And laparoscopy, setting up the equipment, takes a long time. So I think when you have emergency cases where people are bleeding and where people have perforation, it's going to be really hard to do that for Crohn's or UC. But, fast forward 30 years when you guys are my age and I'm in the old person's home, people won't have experience doing open surgery, right? So for them, it might be better laparoscopic. I mean, one of our urologists injured an iliac vein doing a prostatectomy. The vascular surgeon came in, they made a huge incision, they repaired the iliac vein, there was blood everywhere, patient stabilized. The urologist closed and finished the operation robotically because he never does an open prostate, right? So that's a long answer to your question. Are there any absolute contraindications? No. And I think in your generation, you guys are going to do a lot more redo operations than my generation. I think I'm probably up there. If you look at bariatric surgery as an example, when they started doing redos and leaks and conversions from this, from the band to a roux, or from a sleeve to a roux, they used to do that open when it started, right? Or when I was doing them 25 years ago when I first got out and I was in the military, we did them on the dependents, wives and children and stuff. And we would do an open redo gastric bypass, converting a vertical banded gastroplasty to a roux. Now, if you do that open, they look at you, like you're committing malpractice, right? Because they do all of that laparoscopic now, redo, and the patients do better. It's the same thing with Nissens. So I think in colorectal surgery, we're going to move in that direction, Mark-Ian. I personally think that it'll be the robot that moves us there more than laparoscopy and colon.
Thank you very much, Dr. Goldberg. And next question from Olga Ivanchenko, please.
Yeah, thank you. I have one question about toxic megacolon.
Who's
And
asking?
which minimal colonic dilatation is an indication for colectomy in toxic megacolon?
That's a good question, Olga. I don't think that the size alone is an indication. However, if somebody is sick, they're tachycardic, they have a fluid requirement, and their colon size goes from 10 to 15 centimeters, I would be much more likely to say that they have failed conservative management. So I would take that as not the only data point, but one of the data points that we use to make a decision. Increasing distension, okay? Increasing distension with persistent tachycardia, fluid requirement, pain, and a rising white count, that would be one more thing that would push me in the direction of surgery. But say somebody's white count went from 20 to 10, and they went from tachycardia 150 to 100, and their pain got better, and they were making good urine. If their colon went from 10 to 13, I might continue to observe them. So I would use that as one data point. The 5 things that I mentioned are the big data points, right? Their size of the colon, tachycardia, white count, fever, their physical exam, and their urine output, 6 things. And I would take all of those and make a decision, a clinical decision utilizing those. Sophia, you have a question?
Thank you.
Yeah. Good evening. Thank you so much for a great lecture. Lots of patients developed a profuse diarrhea after cold proctectomy and forming G pouch. How you deal with it?
So I usually start with Imodium. There you are. I start with Imodium, and I start with so first of all, I start with fiber, Metamucil, Benefiber, any of those. And then, and some of my partners here, they just start right away. They just start using, they just start with Imodium right away.
What about dosage?
The dosage. So when I use Imodium, I start with 1 tablet twice a day, and then I go to 1 tablet 4 times a day, so every meal and bedtime, and then I go to 2 tablets 4 times a day, and then I add on Lamodal, which is diphenoxylate with atropine, and the max of that is 8 pills twice a day. So I do 1 BID of Imodium, 1 QID of Imodium, and then 2 QID. And then I put on the Lamodal 1 BID on top of the Imodium, and then 1 QID on top of the Imodium, and then 2 QID, and then I add on tincture of opium after that.
Thank you.
And every once in a while, and then when I get rid of them, I leave the tincture of opium, and then I get rid of the Lamodal, and then I get rid of the Imodium. Maybe the tincture of opium alone works. So I work my way up to the big gun. And then the reason in the States, the reason I get rid of the Lamodal first instead of the Imodium is because Lamodal here, the diphenoxylate with atropine, is a controlled substance, like a narcotic. So I don't want to have somebody writing 2 scripts that require a narcotic, a narcotic script every single month. So that's 24 scripts a year instead of 12. And Imodium is over the counter. So that's why I do it that way.
Thank you.
Of course. Mark-Ian.
Yeah, thanks. If you're talking about some kind of dysplasia, high-grade dysplasia, do you try to always do a lymphadenectomy, full extent of lymphadenectomy?
Every time I do a proctocolectomy, I do a TME if the dysplasia is in the rectum. Even when I do a proctocolectomy, I do a TME every time because it's so much easier to remove. So if it's in the colon, I use this expression when I teach the residents, and I knew I was having an impact after 20 years when one of the trauma surgeons who he's probably 12 or 13 years out now, but he was one of the chief residents in my first 4 to 5 years at the Brigham in Women's Hospital. And I used to tell the residents, there were 2 things that I knew I had made an impact technically. Number 1 was the ureter is medial and deep to the gonadal. So when I hear them teaching the residents using my expressions, I knew that had an impact. And then the other one is when you cut down a tree, you don't start at the branches, you take it at the bottom, at the trunk. So whenever I do a colectomy, I always try to stay anatomic, unless it's really bad diverticulitis and I can't stent or feel the ureter, and I know I just need to remove that little segment of colon where the perforation is. Other than that, every single time I do an anatomic dissection, I cut the tree down by taking it at the trunk. So in that case, you would always be doing a proper lymphadenectomy. So
okay, thanks.
I'm sure the trees fall in Ukraine the way they do in the States. Yes.
Yeah.
They do. Okay.
There-
Yeah. Just take the trees at the trunk. You'll be fine that way.
There's also kind of the same opinion, because if you have a huge amount of this kind of operation under your belt, it's easier not to get much bleeding. It's more, as you say, anatomical to do
I agree.
through the told and
Yeah, I find that here when I go help the non-colon surgeons, the general surgeons, and they're trying to do a very difficult ostomy reversal for diverticulitis, they're always mobilizing, and their conduit keeps dying or getting ischemic because they're afraid of being at the root of the mesentery near the aorta and down in the territory where the ureter is, because they're not there all the time. I'm there 6 times a week for 20 years, right? I mean, you know, you're talking 300 times for 20 years, maybe not quite that much, maybe 250 for 20 years. It's, you get very comfortable doing that. And so what happens is they stay too high. And what they don't understand is all your blood supply is based on the marginal artery, where all the branches are, right? And so you're absolutely right. It's a much quicker operation, and it is more anatomic, less blood, and it goes quicker if you cut the tree down by the trunk.
thank you.
Thank you very much. It seems we don't have any more questions. And I just wanted to thank Dr. Goldberg for giving this lecture. I hope you feel better with your hands and after robot. And happy birthday tomorrow.
Thank you very much. If you guys have any questions, get my email from Dr. Melnichuk, from Ali, and I would be happy to email with you for any questions about patients. Anything. Take care.
Thank you. Thank you again, Dr.
Bye-bye.
Goldberg.
Very
Goodbye.
welcome.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thank you.